Okay, so now we will be looking at spinal anesthesia. Spinal anesthesia is done for the surgeries of lower limb, perineum, pelvic, and abdomen are in renal failure, and the mostly lower limb surgeries for spinal block. So it is done at T10 level of umbilicus, and there are some contraindication and indications of spinal anesthesia. Indications include immunocompromised patient, does not impair the cell immediate immunity, elderly or diabetic mellitus patients, and okay, contraindications are absolute and relative. Absolute contra patient refusal, infection at the site, increase intracranial pressure, or there is shock, septicemia, or any coagulopathy, or valvular disease. These are absolute contraindications. Relative contraindications are spinal cord or peripheral nerve disease, brain tumors, CNS syphilis, meningitis, uncontrolled hypertension, anticoagulation therapy. These are relative contraindications, or hypotension or bradycardia. These type of contraindications are there. So after that, we will have to look at the anatomy of a spinal cord. As you can see, a spinal cord has different segments like cervical, thoracic, lumbar, sacral, and coccygeal. Then the anatomy of vertebrae is like, as you can see here, is superior articular process, transverse process, then spinous process, interarticular facet. So these are some processes, and from where you will have to insert the syringe into spinal tap. Anatomy, so which structures we will have to cover for spinal anesthesia. Needle, after outermost skin, subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura, and then subarachnoid space where we will have to inject the drug. So these are some lines that are uh, the 8 lines, 8 layers coverings which you have to cover during a spinal tap. So in this way you have to do. Spinal cords ends at the level of L1 in adults and L3 in children. So dural puncture should be below these levels associated with the slightly risk of damaging spinal cord. If you do that above the L1 in adults, there will be risk of spinal cord damage. An important landmark to remember is that lining joining the top of the iliac crest is at L4 L5 where you have to do spinal tap. You will have to look at the iliac crest and then do that at that position. So spinal cord ends at L1 in the adults, L3 in the young babies and kids. So you have to do tap. A spinal cord ends here, and then you will have to do that in subarachnoid space at L3 L4 or L4 L5. Next one is ending position of spinal cord is known as cara equina, and then it is resembling like the horse tail, and then spinous process are palpable over the spine that help you define the midline, and then you have to look at the vertebral space where you will have to inject the injection, and then that line is known as Taffier's line. Taffier's line, body of L4 and L5 intervertebral space. Taffier's line you will have to inject here in the Taffier's line. Now dermatomal levels, like you have to memorize, this is important. T10 is at umbilicus, T6 at Z4, T4 at nipples, and T12 and L1 at inguinal ligament, crest, and ilium. S4-5 for perineal block. You have to do that. Procedures: prepare the patient, pre-medicate with sedatives, benzodiazepine, midazolam, then monitor the blood pressure. IV preload should be done in thin patients or those who have hypovolemia. Then position should be there, lateral decubitus position, or there is sitting position, saddle block anesthesia in obese patient, pregnant patients, abnormal spinal curvature. We have to do saddle block position, sitting position. Patient should on the table with knees resting, edges of the leg hanging down, and patient should be supported by the stool, and then you have to do position. So saddle block position is very important. Patient should be relaxed, a large area of LS spine in the lower border scapula. Excessive antiseptic removes after waiting for sufficient time, and then you have to do insert the syringe for spinal block. Insert introducer in the midline. Use prevent deflection of the spinal needle. Fine gauge needle can be used. Decrease incidence of post punctural headache. Decrease infection. Avoid skin fragment techniques. So it is very important that you have to keep in the mind, and a needle should be inserted with stilate through the introducer, inserted in the midline, and then loss of resistance can be felt after puncture ligamentum flavum. So as I already mentioned, that there are lines which you have to pierce: skin, subcutaneous tissue, supraspinous, interspinous ligament, ligamentum flavum, dura, subarachnoid, dural, subarachnoid, and subarachnoid space. That where we will have to inject the syringe. So this is very important that you have to keep in the mind. Inject at the rate of 0.2 ml per second. Then you have to aspirate small amount of CSF to determine whether needle is in position. If you are not in position, then there may be chances that you can inject in subdural space. So removal of spinal needle and introducer quickly and simultaneously. So it is very important and practically very useful thing in order to prevent post-dural headache or back pain. As you can see in this image, a spinal step is done. Insertion, passage of spinal nerve, free fluid, then let the free fluid come out in order to avoid pneumo, we say air in the CSF in the subarachnoid space. Then inject the dose according to the patient age, weight, obesity, and then there are different types of the needle: Whitaker needle, Quincke needle, and then sporate needle. Different types of needles for lumbar puncture are there. Then drug that we use in spinal tap is lidocaine, which is rapid in action. Disadvantages is transient neurological symptoms are there, so we have to use bupivacaine, which is commonly used. Amide, it exhibits sensory motor split. Dosage is 7.5 mg per kg, and its concentration is zero point 0.1 to 0.125 or 0.5% is also there, so you have to use according to that. And then ropivacaine is also there, drug used in spinal. That another one is levobupivacaine is also there. So you have to look at the dosage of different drugs and the mechanism of this action. Anesthetic solution injected into subarachnoid space below T10 level. There are three class of nerves: motor, sensory, and autonomic nerves. Simultaneous of motor nerve causes muscle contraction, and when they blocked, muscle paralysis results. Okay. Motor nerves are blocked. Sensory nerves transmit sensation, touch, pain is to the spinal cord, and from there to the brain. While autonomic nervous system control caliber of blood vessel, heart rate, gut contraction. Generally, autonomic sensory fibers are blocked before motor fibers. So mechanism of action. What is the mechanism of action? There is vasodilation, and a drop in the blood pressure may occur when autonomic fibers are blocked. Sympathetic block and autonomic block result into hypotension, bradycardia. That is very important. Practical implication: physiological change. Patient should be well hydrated before local anesthetics. IV agents should be infused, and give fluid should be given. Vasoconstrictors can be given if patient has hypotension. So these things are very important. Interact with receptors situated with voltage sensitive sodium channel, threshold channel, decrease sodium entry, and upstroke of the action potential is there. So opioids can also be used for analgesia, prolonged sensory block, reduce local anesthetic requirement. Opioids like these fentanyl, morphine, and Other opiates should be used. Ephedrine should be used with dosage of 0.2 mg per kg. And then Veracity also looked for spinal anesthetic agent like density of a solution relative to density of the CSF. Hypobaric solution raise against gravity. Isobaric tend to remain the same. Hyperbaric tend to follow the gravity and they settle down. So this is why we have to keep the position of the patient to prevent higher spinal block. Okay, factors affecting block: height, patient age, weight, gender, intra-abdominal pressure, anatomical configuration of the spinal cord, and then technique, site, direction, and the use of barotage or rate of injection. And then other factors are density, amount, concentration, volume, and other vasoconstrictors. Other factors that affect height, posture, volume, pressure, and density, and dosage, veracity, volume of CSF. These things are very important. Level of blocks that are achieved. Okay, so level of blocks that are achieved: sympathetic paralysis causes sensory block, and then motor blockage occurs. Vasomotor blocks dilate the cutaneous vessel. Cutaneous dilation results into cold temperature, sensation of the warmth felt by the patient, and then loss of pain and loss of slow fast fibers, tactile sensation, motor paralysis, pressure sensation abolished, perceptions are lost. And then we have to look at the blockage. Indirect effect of spinal anesthesia. In cardiovascular, sympathetic blockage results vasodilation, resistance, total peripheral resistance decrease, and decrease in the preload, hypotension, bradycardia, fall in BP, postural dependent fall in cardiac output. Indirect effect on SA node is the Mary's law, baroreceptors in carotid sinus sense hypovolemia, and then fall in the blood pressure. Compensatory tachycardia is produced, so we have to take care of that. And then there is brain bridge reflex predominate spinal anesthesia, venous pooling in the peripheral, reduced stimulation volume receptor, diminished action of the cardiac sympathetic vagal preponderance results in the bradycardia. Oxygen consumption is reduced due to hypotension and muscle relaxation. Respiratory effect will be high spinal may cause paralysis of the intercostal nerves, bronchodilation, secondary hypotension, reduced pulmonary blood volume can also cause shortness of the breath. GIT effects: contracted bowel, relaxed sphincter due to sympathetic blockage, in absence of vagal block, increased peristalsis and intra-abdominal pressure. Bladder and urogenital dysfunction can be there. Okay, in pregnancy, there's decreased dose due to mechanical factors like compression of inferior vena cava results into hypotension, shunting of the blood in the venous plexus, and vertebral canal, decreased vertebral canal space, CSF volume. Hormonal factor: high progesterone levels can also cause complications are immediate like hypotension, bradycardia, cardiac arrest, total spinal block leads to respiratory arrest, diaphragm paralysis, and epidural hematoma. Bleeding will be there. Late complications are post-dural puncture, headache, backache, nausea, focal neurological deficit, meningitis, and urinary retention. Treatment: hypotension is due to vasodilation and a sympathetic block, decrease in the effective circular volume. So vasoconstrictors should be given. Hypotensive patients should be given oxygen by mask until the blood pressure restored. Raise their legs, thus increase the rectum and venous blood to the heart. Return of the venous blood. Increase speed of IV fluid infusion to reverse the blood pressure. Treat bradycardia with atropine IV state. In pregnancy, spinal anesthesia causes aorticocaval occlusion. Preload should be given with fluids. Lateral position should be done. Vasopressors and oxygen therapy should be done in the patients. How to prevent delay complications: use thin spinal needles and sterile with precautions. There are different type of the needles are there, so we have to take care of that.